my first talk will be the pediatric cataract and what is the role of the multifocal and torics in children. We all know that the torics and multifocals and the EDOF lenses, the so-called premium IOLs, have definitely made a difference in the adult cataract surgery. They've given a solution for the refractive outcomes in the adult population. But do they have a role in pediatric cataracts? Visual development being a challenge in children, and also the other dilemmas, like we have already these therapeutic dilemmas in children, whether an IOL should be placed at a younger age, and then what type of lens, if at all, we're going to place in children, the biometry, what type of, because we do not have a specific IOL power calculation formula for children, and we also do not have a customized IOL for the pediatric population, and how are we going to manage the posterior capsule. But the general consensus now is to prefer to put a monofocal foldable acrylic lens. The video is not playing. Can you play the video? Not this one. This one, this video. Okay, fine. So the general consensus now, when time tested, we have seen that the monofocal foldable acrylic lens is preferred by most, and it has given good results. But then we have to prime the parent and the child that the child will need glasses for near and distance. This is a surgery showing a video of how cataract is being done in a child, and a 3-piece monofocal lens is preferred in children below the age of 5 years, 5 or 6 years. Why so is because when you operate on a very young child, keeping the myopic shift in mind, sometimes there is a possibility that the child might later on go in for an IOL exchange if there is a gross myopic shift. So that is why a 3-piece lens, because it's easy to exchange a 3-piece lens because additions are less when compared to the single-piece IOL. And what is the expectations of the parents? First of all, when you tell them surgery, they are very disappointed, and then you tell them surgery with or without intraocular lens and glasses for lifelong, they are very disappointed. The first question they ask, can my child get rid of glasses at some point at least? But based on the age of the child, you have to give them what is expected out of the surgery, and you want to maintain good binocular single vision and stereo acuity. And what is the advantage, or what is the debate between the monofocal lenses and the premium IOLs? The present era, we are already having this issue, like I already mentioned, how early to implant an IOL in a child. The different school of thoughts. Some people say unilateral cataract at 2 weeks or 3 weeks of age, bilateral usually after 6 weeks of presentation, or the age, I would rather say, and the lot of advances in technology. So what type of lens can be used in these children, and what is the role of multifocal lenses, which I'm going to talk about shortly, and the role of refractive surgeries to fix the residual refractive error. Why do we really have to talk about multifocals in children? Because we all know that in adults, already the presbyopia is set in, so there's not much of loss of accommodation, whereas in children, when you intervene at a very young age, there is, these children lose accommodation. So this can sometimes lead to abnormal development of binocular vision. And multifocal lenses in children, one is definitely the age at which you're going to intervene. So older children will be the ideal candidates, and you need precise biometric measurements and precise IOL power calculations, and always aim at emmetropia or slight residual hyperopia, which can range from 0.25 to 0.5 diopters. And again, IOL power selection, younger the patient, more difficult. That's why I said the age group usually is above the age of 10 or 11 years of age. And also based on your biometry, if it's on the myopic side, I would probably defer to put a multifocal lens, because sometimes there might be a gross myopic shift. And finally, you have to calculate for the refraction in adulthood. So this is just a multifocal lens being implanted in a 12-year-old boy. I'm using the Varion guided system for the centration of the capsulorhexis, and we very well saw it was an intumescent lens. So I did a small rhexis, removed part of the cortex. I'm doing a secondary rhexis and do a thorough cortical cleanup, especially in a patient with a multifocal lens. Do not have any financial interest, but this was a panoptics lens from the Alcon. So once you place the lens in the bag, and invariably these children will go for a posterior capsular fibrosis. A good primary posterior capsulotomy should be done, but the anterior vitrectomy can be deferred because the older child usually do not go in for a opacification of the anterior vitreous space. And the merits, definitely there is a rapid visual rehabilitation for near, intermediate and distance. There is improved chance of binocularity in these children, and there is also a reduced risk of amblyopia, accumulative blur, and then the children do not have to wear bifocals, and they also have a proper focus of the image. And the demerits, like one is the age. IOL prediction calculability is very difficult. You cannot predict the thing, and then very important is you need the child's cooperation, because you have to have a precise biometry and you have to have a good support of an optometrist to get those values. And in very young children, the refractive stability is again not predictable, and visual development of the pediatric eye, because of the non-optimum multifocality, sometimes can cause abnormality in the visual development, because children do not usually complain. And again, centration issues, because some children can develop more inflammation, so PC fibrosis, anterior capsular phimosis, decentration of the bag, so all that can cause centration problems. Again, the outcome when you compare between adults and children, usually adults have complaints related to glare and halos, and there is loss of contrast sensitivity, whereas in children usually they do not complain, they withhold or fail to come out with the symptoms, and there might be a loss of intermediate vision, and contrast sensitivity sometimes may exaggerate the amblyopia. And this visual nuisance, what is being coming out as complaints with the adults, are not usually made by the children, but then it can sometimes disrupt or make changes in the visual development. And other challenges surgically, you have to be very careful. You need a proper incision, you need a proper bag to place a multifocal lens. So as we all know, as pediatric cataract surgeons, it's not very easy like in adults. So there will be a push, there will be increased pressure, all that you have to keep in mind. So that is one thing you have to keep in mind. The other challenges post-operatively, even excellent surgery, inflammation sometimes can cause posterior synechiae, like PC opacification. This picture here showing air capsulotomy being done in spite of the PC posterior rhexis done, there was opacification. So all that should be kept in mind, and in rare cases you may have to go in for a IOL explantation exchange. But one thing to keep in mind is, if you do a proper selection of IOL, this will not happen 90% of the times. And just to reinsure, and this is just some of the studies which were done as early as 2001. They have done 35 eyes, 26 patients, and they said that at least 10 of these eyes required a secondary surgery. And this is just to kind of giving you some evidence that it has been done from 2001, but now it is recommended that multifocal lenses can be a choice in older children. And again, this is another study, 2010, Cristobal et al. They did this study, 5 children. The number of children were very less, and the minimum follow-up was almost about 21 months. And they are also saying that long-term results have been done. And we at Aravind Coimbatore have done around 10 patients so far, and they are fairly doing well. Most of them are doing well. We do not have a long-term. We have only a follow-up of up to about 3 years, and so far the results have been good. So to conclude, definitely multifocals can be an option in older children. Always keep in mind the relative shift, and also there is a chance of degradation of amblyopia due to loss of contrast sensitivity. And even today, the hydrophobic monofocal acrylic lenses are the choice of lens, but do keep in mind these are also option, but we do not have long-term results, but it can be kept in mind for older children. So coming to toric IOLs in children, again we all know that at birth children are usually having an against the rule astigmatism, and then with growing age they became with the rule, and later on as they get older they usually become against the rule astigmatism. And toric IOL usually above 1.5 diopters definitely have a have a role in dealing with children with cataracts, gives them a better unaided visual acuity for distance, and also reduces the risk of amblyopia. So like I already mentioned, usually about 1.5 diopters above the age of 10 years, I would say, but all exclude children with other pathology, other fundus pathology or subluxation or keratoconus. So you need to do all the investigations. You have a corneal topography and measure the corneal thickness, roll out keratoconus, and postoperatively the refraction keratometry should be checked at every visit. Again, the toric marking should be done before the induction of anesthesia, making the child sitting up position using a topical anesthetic drops. And this is a video of a toric IOL being implanted. Again, the Varion guided system is used and the toric marking is done. So this was a 11-year-old boy with the 2.5 cylinder. So all these premium lenses is very important to have a adequate sized centered rexus. So that's very important to keep in mind. So do a thorough cortical cleanup. Just one moment. And the toric IOL is implanted. The axis is 92. So well centered lens in the bag, and this is preferable. If you're comfortable and if you think you can do a primary posterior rexus, it can be done. If not, you can leave alone the child. Later on, if there's a PC fibrosis, we can always go for a IOC capsulotomy. And the wound is always closed with a 10-0 Weichel suture. And this child also had a vitreous disturbance, so vitrectomy was also done. You can see postoperatively, it's a well aligned lens with a good clear visual axis. So to conclude, definitely the premium IOLs are a choice. And regarding the EDOF lenses, I did not mention. I think I was going through literature. It is also coming into use in the pediatric cataracts, but I do not have much of experience on that. But we've just started doing it. Anyways.